Hello, this is Dr. Robert Gish here to present an update on fatty liver disease. I am based in San Diego, Sinjiao, Qivi, checking to make sure audio and video connection is good. And now we will move to the slides. Thank you so much for having me today. Mafld. Don't be baffled by Mafld, the new term for non-alcoholic fatty liver disease. Mafld is metabolic associated fatty liver disease, although there's much controversy about this name change. I'm going to use what I think is best and state of the art. Disclosures and many resources are available through my website. We've been going through a very disturbing recent evolutionary development. Increased fructose, decreased activity, environmental toxins such as bisphenols, many problems, including genetics, which we'll talk about today. More on terms, NAFLD. We rarely call a disease that's not something non-alcoholic. And alcohol terms can be stigmatizing. And there are patients that are missed by this terminology, and there's alcohol use that's missed by this term and this assessment. Mafld is more expansive, inclusive, and non-stigmatizing. When you see the word NASH, that indicates inflammation and typically fibrosis. Steatosis is for simple fatty change. We also have alcohol-induced steatohepatitis, alcohol-associated liver disease, alcohol use disorder, and alcohol-related hepatitis as part of our terms. If you have a combination, people have come up with clever terms such as CASH or BASH. NASH is part of a multi-system disorder. I'd like to remind you that this deck is downloadable. We'll be moving quickly, although I'll try to speak slowly to make sure all translation and understandings are intact. This is an inflammatory condition that affects vessels, heart, liver, pancreas, kidney, increasing risk for brain injury such as stroke, accelerating bone degenerative disease because of weight. Even more, depression, CNS changes, low quality of life, infertility, sleep apnea, sleep disorders, which can make fatigue worse, gout, and other inflammatory conditions. I show each of my patients the 6-pillar concept and talk about shorter lifespan, but reverse that discussion, asking them, do they want a better quality of life? Do they want to live longer? And we talk about decreasing the risk for 13 different types of cancers with weight loss and controlling their metabolic syndrome, as well as liver-associated, kidney, and cardiovascular. Even more details are here, such as hypogonadism, thyroid disease, and the psychopathology is substantial in patients with fatty liver, including 25% having depression, 10% anxiety disorders, and a variety taking different psychoactive medications. The word on this slide that's most important is lipotoxicity. The liver is a central core repository for fat and releasing inflammatory mediators. We're moving forward with alcohol-associated liver disease and metabolic-associated fatty liver disease. And during the COVID era, we had an incredible increase in alcohol-related hepatitis. Fortunately, chronic hepatitis C and B continues to improve with effective therapies. There is no safe level of alcohol use in patients with fatty liver. There have been some positive statements, definitely negative statements, but we haven't identified a safe threshold. So I advise patients not to drink alcohol. This is a global disease that's associated with excess calorie intake, especially excess in relationship to activity. But you can see here, the Middle East has actually got the highest prevalence. And that also has to do with calorie intake, type of diet, and low activity levels. This is a simple diagram that talks about a normal liver, simple fatty change, fat plus inflammation, fat, inflammation, fibrosis, specifically here, cirrhosis. The worldwide prevalence is quiet, quiet. Shh. Go rest. Go rest. Be quiet. Thank you. Very important here to be thinking about the risk for hepatocellular carcinoma as well. This multi-hit hypothesis is very important, recognizing cytokines, adipokines, oxidative stress, apoptotic pathways are involved. A high focus on insulin resistance. You can calculate insulin resistance in your patients by calculating the HOMA-IR. This is fructose based, at least in part. Increased fructose, increased weight, decreasing activity, genetics, bisphenols, abnormal biome. We'll be talking about those factors today. Remember, with fructose, you have this carbohydrate that's converted to fat very easily, but very important that fructose actually becomes a mitochondrial toxin and results in ATP depletion. The intestinal microbiome modulates insulin resistance and metabolism, and a vegetarian diet is considered anti-inflammatory, and a beef, meat-based diet pro-inflammatory. We're having a crisis because of an increase in fatty liver-associated cirrhosis, liver failure, alongside alcohol, becoming dominant now as the indication for listing for liver transplantation. This gives you more detail about etiology among adult liver transplant weight registrants in the US, where you're seeing a marked increase in alcohol and metabolic associated fatty liver disease. This is true in both men and women. New guidance has come out for metabolic associated fatty liver disease management, including in patients who are lean. You'll see in many Vietnamese patients a modest BMI, 22, 23, but fatty liver. And they'll say, I'm not overweight, I'm not obese, but they have truncal obesity. They have an increased waist circumference. And that fat around the intestines becomes lipotoxic and moves fat into the liver. You should be assessing these patients with elastography, as well as tests such as APRI and FIB4. Look at the AST to ALT ratio. Look at the platelet count. This represents about 20% of all fatty liver disease. You need to change lifestyle, increase exercise, decrease fructose intake, vegetarian diet, consider probiotics. This talks about cardiometabolic abnormalities across different body mass index. These patients with lean fatty liver, or we'll call it normal body mass index fatty liver, also have an increased risk of cardiovascular disease, atherogenic dyslipidemia, high C-reactive protein, an excellent inflammatory marker, hypertension, and hyperglycemia. Lean NASH is important, especially in the Vietnamese population, and you need to manage this as aggressively as you would with obesity-related fatty liver. This is very, very important that patients with fatty liver have an abnormal or low quality of life. This has been documented with a number of tests, including what are called patient-related outcomes, quality of life tools. There's a visual analog scale and other tools to document this quality of life issue. This is part of the motivation to change your patients, that they can improve their quality of life, their sleep cycle, their energy, to have a more productive and happy life by losing weight. This is very, very important, that the quality of life is separate from the fibrosis stage. So even patients with early fatty liver disease, minimal or mild fibrosis, have this decreased quality of life. This is progressive in a subset of patients, and that progression risk relates to genetics in many ways. So people are programmed to be progressives or non-progressives. But unfortunately, we don't have genetic profiling commercially available. You can get this through different gene sequencing laboratories, but right now you'll be determining who's progressing by monitoring your patients, restaging those patients annually with imaging and blood non-invasive testing, not liver biopsy. This gives you those numbers about progression to cirrhosis in the 15% range and onto liver cancer in the 7% range. I'd like to highlight that liver cancer can occur in non-cirrhotic patients, typically stage 3. We don't know the exact risk, and the population base is huge. I'm doing surveillance on my stage 3 fatty liver patients if they are triple liver cancer biomarker positive, or using a new test from Helio liver risk test for liver cancer, and then deciding who needs ultrasound or more advanced surveillance imaging. This talks about fatty liver in general, and then fatty liver plus inflammation and fibrosis by subgroup. So you can see in a stepwise way, diabetes, high BMI, and hypertension are correlated with that high prevalence of inflammation and fibrosis. So individual factors increase risk, multiple factors markedly increase risk. Now, what I want to highlight on this slide is the gamma GT. I order a GGT on all of my liver patients. I consider that one of the 4 pillars of liver enzymes. Remember, ALT, AST, GGT, and alkaline phosphatase are not liver function tests. These are liver enzymes. This GGT is a surrogate for cardiovascular disease and cardiovascular events, as well as risk of diabetes. Fibrosis ultimately drives outcome, and this is why you want to stage each patient. So those patients who are developing fibrosis are going to develop progressive liver disease if they don't change their behavior, their weight, and their fatty liver. This talks about liver-related mortality, but I want to say that liver-related events, complications, and mortality are third. 2, number 1, cardiovascular and heart disease. Number 2, cancer. There's over 13 types of cancers that are increased in patients with fatty liver disease. A little bit more on this from Angolo's article in 2015, listing cirrhosis and transplant as third and behind cardiovascular and cancer. Liver has the highest relative risk of cancer due to obesity in this cancer prevention study, but most important on this graph is lifting off the different cancers that are increased in patients with fatty liver: kidney, myeloma, gallbladder, colon, rectum, esophagus, stomach, pancreas. But of course, liver is number 1, and that's why we do surveillance for liver cancer in at-risk individuals, all cirrhotics, and selected F3, fibrosis 3. Obesity and this inflammation changes the immune system. This is a complex discussion, but diseases such as COVID, which require an intact immune system, may be more severe and may cause more severe liver disease due to this immune modulation of obesity in patients with MAFLD and COVID infection. There's an inflammatory state, increased estrogen production by fat, higher insulin growth factor and insulin levels that I consider pro-carcinogenic. So in a diabetic patient, you only use insulin if they have low C-peptide. If their C-peptide is normal or high, you are not going to use insulin. You'll use metformin, You will add a GLP-1. You will consider an SGLT2 or a DPP agent. You will not use the old sulfonylureas, and you will not use medications such as pioglitazone. Fastest growing cause of HCC is fatty liver. We must keep this in mind when educating our patients and deciding on cancer risk and surveillance strategies. This is data from the US. This followed information coming from Japan and other places where liver cancer in fatty liver patients can occur in non-cirrhotic patients. This is concerning. This is a list of major genetic modifiers of fatty liver risk and progression, but let's move to the lower right-hand corner of the slide where it talks about genetic modifiers of fibrogenesis. I believe within 1 or 2 years, you'll be able to order a commercial kit and get results such as PNPLA3, TM6SF, MBOT, HSD, and other markers of increased risk. And this may further allow you to motivate and educate your patients to lose weight, modify their lifestyle, and take some of our new upcoming medications. You need to work up every patient with fatty liver, and you need to work up every patient at risk for fatty liver by assessing for fatty liver with blood tests and imaging. Take a meticulous alcohol and medication history. You need, of course, to rule out autoimmune liver disease in a subset of patients. Liver biopsy only useful in select patients or for clinical trials. Imaging techniques are excellent, but I think this elastography, including FibroScan, gives you liver stiffness and a CAP score, controlled attenuation parameter, that gives you that fat concentration. This is what I use, either this machine or a new one called VelaCure from Sonic Insights. And there's new modules on Hologic's Explorer system that allow you to determine fat as well as liver stiffness. What about using FIB4 or APRI? Well, there's a large number of patients where it says indeterminate. I'm going to change the word to intermediate. Very, very important terminology here, because in that intermediate zone, you need to do a second or third or fourth test. FIB4, though, is accurate up until about age 60, when age amplifies or overestimates fibrosis. ELF is a new commercial test available in the US and in Europe. It's a combination of TIMP1, hyaluronic acid, and this procollagen P3NP. This combination has a label to predict the future, the risk of progression to cirrhosis, and the risk of complications. I have not ordered this yet in my practice, but as a consideration in patients where I think there's significant confusion. Diet works, exercise works, surgery works. We need to get our patients to lose weight. It's absolutely critical, but should be non-shaming, non-stigmatizing. You're a partner. You should be using motivational interviewing to talk to your fatty liver patients. Weight loss leads to improved health. Look at all of these markers we've been talking about, these complications of inflammatory fatty liver disease that improve with different levels of weight loss, highlighted in blue across the bottom. This is interesting that a low-carb, high-fat diet improves fatty liver better than a high-carb, moderate to low-fat diet. And I believe this is because when you have a high-carb diet, you have cycles of hunger and fatigue. On a low-carb diet, high-fat, you don't have this appetite drive to be consuming calories. Exercise works. 3 times a week, 400 kcals per session is highly recommended. There are a number of anti-obesity medications that can be used to change that CNS drive or craving for food intake and carbs. I don't use orlistat because basically it causes malabsorption, but many of these other drugs can be used to help manage obesity. Liraglutide and semaglutide, as well as some of the new combo GLP-1 GIP medications, are resulted in marked weight loss. I do not use pioglitazone or anything in this family because I think they're associated with weight gain, fluid retention, cardiac complications, and maybe cancer complications. Metformin, on the other hand, is foundational. And then you're going to add your other agents to this. Vitamin E from the Prevalence study did have a beneficial effect over placebo. Pioglitazone also had a benefit, but I think it has a number of risks, whereas vitamin E has minimal risks. We can generalize the vitamin E benefit to diabetics, but less helpful in cirrhotics. It's vitamin E, natural, 800 international units per day. Every fatty liver patient I have with significant fibrosis is on vitamin E. ACE inhibitors recently showed a benefit in managing fatty liver disease. And here's a list of potential mechanisms and potential effects. So ACE inhibitors and non-cirrhotics, I use carvedilol in patients with cirrhosis and portal hypertension. Obeticholic acid is still under review at the FDA. It did show a benefit in their large phase 3 trial, but due to safety concerns from the FDA, which we already knew about, they decided they wanted more real information about benefit and more safety information to balance risk and benefit. Liraglutide, the first GLP-1 that came to market, and now we have semaglutide that includes long-acting injectables and oral versions. Most recently in the news was efruxifermin. This is a phase 2b harmony study with this combined agent GLP-1 GIP that showed marked improvement in fibrosis, NASH resolution. It's really amazing, and these patients could lose up to 25% of their body weight. Watch for this new medicine closely. Well, how about some pearls? Diabetes patients all need a fatty liver workup. All fatty liver patients need a diabetes workup with hemoglobin A1C. I use statins across this group of patients, targeting LDL in the 60 to 80 range. You can use a variety of medications, including bupropion or Effexor as an antidepressant, since these SSRIs specifically have weight neutral or weight loss. The Effexor is much more of a norepi inhibitor as opposed to an SSRI. So Mafld is a systemic inflammatory process with associated cardiovascular, renal, cancer, specifically heart failure, heart attacks, stroke, orthopedic problems. There are many motivators to get patients to lose weight if you approach them through a positive construct, a motivational construct. Rarely do we biopsy these patients unless there's an overlap syndrome or a clinical trial. They need to be smoking-free, alcohol-free. The top coffee and tea can be quite helpful. Weight loss goals, at least 10%, but I really tell my patients I want them to get to a healthy body mass index of 24 for Caucasians, African Americans, Hispanics, and 22 for Asia and Asia Pacific Islanders, except for maybe people from Samoa or Tahiti, where they have much larger body size. Exercise key, vitamin E important, statins are safe. Bariatric surgery is a solution, but expensive. Every patient with fatty liver should see a dietitian, nutritionist. I have all my patients sign the weight loss contract. Vegetarian diet is better, and Mediterranean diet is great. Looking at the bottom here, 5 red boxes, a variety of new targets and new drug development are taking place throughout the world. This is some recent active information about improvement in fibrosis with a variety of medications, including lanifibranor and resmetirom from Madrigal, which is an excellent medicine that will hopefully be on the market soon. On the far right is Ocaliva, which was first to get their studies done, but showed a relatively weak effect. Future of clinical medicine and fatty liver will be a personalized approach. Motivational interviewing, genetic testing, educational programs, support, sponsors to help improve their health and their liver status. want to thank my little sister, Hang Dao, Sin Kamon Yu. Acknowledgements also go to EASL, Mafld, Hepatitis B Foundation, HepDart, Stephen Harrison, my mentor in the fatty liver space, as long as Said Mazen Nuruddin, Naeem Al-Khoury, just a fantastic group of people leading the charge in this world, including the NASH Forum.